Now I invite Dr. Leena Mariyam Varghese. She is Assistant Professor of Ophthalmology, Believers Church Medical College, Tiruvalla, and she will be talking about MSICS in hard brown cataracts. Welcome, Dr. Leena.
Good afternoon all. At the outset, I'd like to thank Philip sir for giving me this great opportunity. I also appreciate the efforts of the organizing committee for conducting such a wonderful conference. I'll be talking on management of hard cataract. So these are the contents I'll be following. So why is SICS important in hard cataract? It is the best method to tackle complications of hard cataract, especially for beginners. It is a cost-friendly and effective surgery with good visual recovery, especially in remote areas and camps. There is reduced endothelial damage if you make a large tunnel, reduced chance of PCR or nucleus drop, and better nucleus delivery and IOL placement even in case of zonual weakness. Pre-op assessment is crucial in all cases of hard cataract. Why? Because hard cataracts are usually associated with reduced endothelial cell count, poor pupillary dilatation, and subluxation of the lens. The IOL power calculation best method would be immersion technique, and you should do B-scan in all cases where you do not see the fundus to rule out any retinal pathology. Proper patient counseling is required as we expect complications in such patients. What are the difficulties? As I've mentioned before, the things that we should keep ready when we have difficulties are an extra viscoelastic to protect the endothelium, pupil expanding devices in case of small pupil, a CTR in case of zonual weakness, and a vitrectomy cutter if you expect vitreous prolapse. How to tackle? You prefer peribulbar anesthesia. Why? Because you think the procedure will take more time and there is more chance of complications. You need to have a superior rectus suture to fixate the globe downwards and cause countertraction during nucleus delivery. When you do a conjunctival peritomy, you have to be careful that you remove the tenons also, because when you make a scleral incision, can we close this? So when you do a conjunctival peritomy, you should make sure that you remove the tenons also, because you need to have a proper scleral incision, and you should have wet cautery to prevent intra as well as post-operative hypema. In case of small pupil, you can use intracameral epinephrine, and you can use dilatation devices such as iris hooks or Malugnin ring, or you can do stretch pupilloplasty. The problem with capsulotomy in a hard cataract is there's a poor red glow and the capsule is quite thin. So you need to stain the capsule with trypan blue dye to enhance capsule visibility and also decrease capsule elasticity. Always keep the antechamber well formed before doing the rhexis. CCC is the ideal capsulotomy. When you do CCC in hard cataract, make sure you have a large rhexis because it helps in easy nucleus prolapse and gives less tension on the zonules. Can-opener capsulotomy can also be done. It is mainly done when you have a rhexis escape or in presence of fibrosed or calcified capsule. Another thing that you can do is, in the region of the calcified or fibrosed capsule, you can use a microrhexis scissors and continue with your rhexis. Can-opener has more of disadvantages mainly because of the capsular tags, while CCC has multiple advantages such as no chance of any extension. You can do a safe hydrodissection. It has good capsule strength. You can properly place the IOL in the bag as well as in the sulcus in case of a PC rent, reduce PCO formation and long-term stabilization of refractory outcomes. When you make a sclerocorneal wound in a hard cataract, it has to be a large one because you need to take out a large nucleus. The external incision should be about 8 millimeters and the internal incision should be larger because it does not expand as well as the external incision. You should give good scleral pockets to accommodate a large nucleus. You can make Blumenthal side cuts in order to provide a large tunnel as well as large scleral pockets, and there is minimally surgically induced astigmatism. When you enter into the antechamber, make sure that you use a sharp keratome to prevent DM detachment and move forwards and lateral, and you should open up the whole tunnel. In subluxated cataract, the rhexis is difficult because of weak or absent zonular countertraction. Hence, you can start the rhexis with a cystitome. It is better to start off away from the region of subluxation, and once the flap is raised, with the help of a forceps, hold on to the flap and enlarge it. Whenever you're using a forceps, make sure that you pull towards the center. You can use a CTR before nucleus delivery. You have to place the CTR carefully into the bag. And when you're placing the trailing end of the CTR, make sure that it does not go behind the iris, it goes into the capsular bag. Doing a careful hydro is important because there is no visible fluid wave. You have to express out the viscoelastic before you do a hydro. Be very careful that you do not cause a capsulolenticular block. This happens when you have a small rhexis. You will see that pupillary snap sign. So in order to prevent a capsulolenticular block, you need to have a large rhexis. You should tap the nucleus in between your hydro. You can have multiple irrigation points followed by simultaneous decompression and dial the nucleus to relieve all the corticocapsular adhesions. When you dial the nucleus into the anterior chamber, you can either do it by hydroprolapse or you can use bimanual technique where you use two instruments to bring the nucleus into the anterior chamber. While delivering the nucleus, make sure that you inject viscoelastic above as well as below the nucleus to protect the endothelium as well as the posterior capsule. Use a irrigating vectors to take out the nucleus. The advantage is the irrigation gives extra advantage by pushing the nucleus out from the anterior chamber. Now, if your tunnel is small, you might actually cause fracturing of the nucleus. In that case, slowly inject viscoelastic, push back the nucleus very carefully, make it vertical and take it out again with the help of a irrigating vectors. The other methods of nucleus delivery are sandwich method, where you sandwich the nucleus between a dialer and a irrigating vectors and take it out. Or you can do visco expression by injecting viscoelastic into the anterior chamber. You place the visco cannula below and beyond the nucleus, press on the posterior lip and the nucleus will easily come out. You need to have a large tunnel in this case. You can use nucleus snare where you engage the nucleus within the snare, cut it into two and take out each half with the help of a forceps or irrigating vectors. You should do a thorough irrigation aspiration of the cortex to reduce uveitis, CME or post-capsular opacification. Place the IOL into the bag or in the sulcus in case of a PC rent. If there is a doubtful wound integrity, it is better that you close the wound because it may induce against the rule astigmatism. You can either use interrupted or infinity or X suture. Infinity is better because there is less surgically induced astigmatism and you will bury the knot, so there is not much of irritation to the patient. Post-operative, you can control the infection with subconjunctival steroids and antibiotics. You can give them topical steroids. If there is rise in intraocular pressure because of the inflammation, you can give anti-glaucoma medications. Take-home message, you need to have a detailed pre-op assessment, a large scleral wound, good rhexis, careful hydro, safe nucleus delivery, always protect the endothelium and be ready to tackle possible complications. My acknowledgements, references. Thank you.
Leena. Thank you, Dr. Leena Mariyam, for the excellent